Hello friends, how have you been during all these days? Hopefully you would have been enjoying your this summer and summer holidays. Many of you must be on summer holidays on the vacations, and they would be enjoying these hot summer somewhere near the beach, somewhere on the hills, and somewhere else where they want it to be. So welcome back to Dr. Arshad Nadeem Awan teaching video. So I want to just send some of the spices and some of the what I would say here, academic knowledge during all these days. If you are feeling very hot, so I'm sure this hotness will be reduced to some extent by understanding all these videos. So today my topic of discussion is ovarian neoplasm. Ovarian neoplasm, as I mentioned in my previous videos, I have discussed about one of the table. I have given it to you. These table include the types of the ovarian neoplasms. Mainly ovarian neoplasms are 4 types. This I'm gonna just repeat for the purpose of that how I will go about these ovarian neoplasms, so you should have a clear idea about that. As far as ovarian neoplasms are concerned, these are mainly categorized into 4 types. Number 1 is called as surface epithelial stromal cells. Under the surface epithelial stromal cell, there are few neoplasm which I will discuss separately. The second is germ cell tumor. Under the category of germ cell tumor, there are few important germ cell tumors which I will discuss separately. The third is called as sex cord stromal tumors, which would be a separate entity, and there are few tumors related to sex cord stromal tumors. And the fourth one is metastatic. So these are main 4 categories for the ovarian neoplasm. Today what I'm gonna do is I'm gonna just select one of the topic, and that is surface epithelial stromal cell. Surface epithelial stromal tumors are important tumors. It accounts 80 to 90% of the malignancy of ovaries. So that's why it is the first one and the important one you must pay attention to. Today my video is about the surface epithelial stromal neoplasm. Surface epithelial neoplasms are considered to be arise from the surface epithelium, as the name show. Therefore this name has been given to these tumors because it arises from the surface epithelium. Under this category, there are 5 main types of the tumors. There are cystic, these are serous, these are transitional cells tumor, these are clear cells tumor, and these are endometrioid. So these 5 are considered to be a surface epithelial stromal tumors, and I mentioned that these all accounts for 80 to 90% malignancy of the ovaries. So again, the serous, the mucinous, the endometrioid, the clear cell, and the transitional cell. Transitional cell tumor is also called as Brenner tumor. So Brenner tumor is a particular name given to the transitional cell tumors. So far all these tumors are concerned. There is a dualistic approach. There is a dualistic explanation which categorize these cancers into 2 categories. The one is type 1 and the type 2. So type 1, under the type 1, they call these cancers as low grade serous, low grade mucinous, low grade endometrioid, and low grade clear cells. So these falls under the category of low grade carcinomas. The type 2, under the dualistic category, the type 2 cancers are considered as a high grade. These are serous carcinomas, these are undifferentiated carcinomas, these are endometrioid carcinomas, and these are carcinosarcoma. So make your mind clear that under the dualistic criteria, there are 2 main types of the cancer. The one is low grade potential or low grade malignancy or low grade cancer, and the second is called as high grade malignancy or high grade cancer. How these cancers spread, especially I'm talking about the surface epithelial stromal tumors. So surface epithelial stromal tumors spread through peritoneal extension. So they seeding, they goes through the endometrium and they spread elsewhere. The second spreading method is contiguous. Any other organ which is nearby or adjacent to the cancerous tissues, this cancer will invade that organ and it will spread to the adjacent organ as well. The third one is lymphatic extension. Through the lymphatic, these cells goes and erode the para-aortic lymph node. So that would be through the lymphatic extension. The fourth extension is hematogenous, which is very rare, and it happens when there is extreme case, or that there is which we call is a later stage or end stage. So at that stage hematogenous spread will take place. So these are all the category which I have explained about the surface endometrial stromal tumors. Serous cystadenoma and serous cyst adenocarcinoma, these two types of tumors are considered to be surface epithelial stromal tumors. So first I would talk about the benign one, which is called as serous cystadenoma, and then I will talk about the malignant one, that is called as serous cyst adenocarcinoma. So far the serous cystadenoma is concerned, this is benign tumor. 50 to 70% it accounts because it's benign lesion, and it happens in women with their 50 to 60 years of life. It means in 5th and 6th decade of life it's usually common. And as I mentioned, this is a benign tumor. On the ultrasonography you will see it would be unilocular, but at times there may be thin septation or there may be papillary projections within it. As far as malignant is concerned, malignant is called as serous cyst adenocarcinoma. It accounts for about 50% of malignancy, and it usually seen in perimenopausal ladies and postmenopausal ladies. On the ultrasound imaging, you would see there will be multiloculated cystic lesion with thick septations, and around the wall there will be a papillary projection, and there will be internal debris as well. Beside this there will be ascites, and ascites would also be present. How we will pick all these benign and malignant lesion, how we will pick serous cystadenoma, and how we will pick serous cyst adenocarcinoma? Let's start watching these imaging, and hopefully you will be able to pick these two important points, because these two tumors are very common, and this is on the top, and as I mentioned, it accounts from 70 to 90% of the ovarian neoplasm. Although the category of benignicity and malignancy I have already shown, but you have to pick the point whether this is cystadenoma or this is cyst adenocarcinoma. But these are all serous cysts. So let's start watching these images. In this abdominal scan, you can appreciate a well-defined complex cystic lesion. This is serous cystadenoma. Just focus on, you can appreciate thin septation within the cystic lesion. However, there is no thick wall. This thin septation sometimes mimic as multiple confluent cyst. Many clinicians write the report that multiple confluent cysts can be seen. Make sure that these are septa, and you should not confuse with the confluent cysts. As far as the internal lumen is concerned, there is no low level internal echoes, just thin septation can be seen, and in the surrounding area no thick wall. So this is a typical example of serous cystadenoma. Serous cystadenoma is a benign lesion, and it comprises of thin septa. There is no thickness in that, usually fairly thin septation you would be able to see in that. However, internally there will be no low level internal echoes, and if you put the Doppler signal on, there seldom vascularity, so there will be no vascularity at all. So this is an example of serous cystadenoma. Another slide of transvaginal scan is provided here. Just concentrate on, you will appreciate a complex cystic lesion, fairly well defined, round in shape. There is no internal echoes within the cystic lesion. As far as the outer wall is concerned, it's also thin. Internally you can appreciate thin septa. The septation thinning is very important. Look for, because this is the major differentiation between the mucinous cystadenoma and the serous cystadenoma. In serous cystadenoma there will usually be thin septa, and there will be no wall thickening, and there will be no low level internal echoes within the cyst. Always put the Doppler signal on and confirm the vascularity. If septa shows vascularity, so this would be a malignant tumor, and this will show malignant potential. Therefore vascularity is very important. Always put the Doppler whenever you come across any septation within the cyst. If there is vascularity, it's mean it has malignant potential. So definitely this would be towards the cystadenocarcinoma, but here there is no vascularity in that, so this is a clear example of simple serous cystadenoma. As we have already discussed the simple form of cystadenoma, this is cystadenocarcinoma, as this is a malignant tumor. So now focus on the slide. This is transvaginal scan, and on transvaginal scan you can appreciate fairly complex cystic lesion. Predominantly it is cystic lesion, but within the cystic lesion there you can appreciate multiple nodularity. There are echogenic nodules within the cyst, and beside this there are multiple thick septations. Low level internal echoes can also be seen in this cystic lesion. If you see, sometime clinician may confuse that this look like a solid mass, and within the solid mass there is cystic degenerative changes, but this is not. In this case, this is not the solid mass. What you have to do is you have to always look for the outer boundary. If the outer boundary is cystic, so it's mean that is basically a predominantly cystic lesion. If surrounding is thickened or soft tissue, or it shows soft tissues component or thick wall or something surrounding the soft tissues component, so that would be solid mass. But here in this case you can appreciate these are all the cystic areas. Beside this you can appreciate well defined thick septation, and this is example of serous cystadenocarcinoma. Another example of serous cystadenocarcinoma has been shown on transabdominal scan. Here on this transabdominal scan you can appreciate a well defined complex cystic lesion. This is not transabdominal, this is again transvaginal scan, and on this transvaginal scan you can appreciate fairly complex cystic lesion, and on that cystic lesion you can appreciate thick nodularity within the cystic lesion. So these are two information related to carcinoma or malignant status. The one is thick nodularity, and second is thick septation, and the third thing is low level internal echoes. How you can confirm that these nodules have malignant potential? The Doppler imaging. Doppler imaging always play a very important role to differentiate between the vascularity. When there is something vascular, it shows that it has been supplied by the nutrition and supplied by the blood, so that would definitely be a malignant potential. So this is what on this image you can appreciate. This image shows vascularity. So this is serous cystadenocarcinoma, well defined complex nodularity within the cystic lesion. Beside this, vascularity is visible, so this is confirmed serous cystadenoma example. This is another transvaginal scan. Rather I would say this is the same scan which you have seen in the previous image, just to make you sure that this is high vascular lesion, and in high vascular lesion you can appreciate a high diastolic flow resulting in a low resistance index. So this is high vascularity with a high diastolic flow. Here you can appreciate all the signal has been given just to give you an idea that if there is vascularity, you always confirm its resistive index is also diastolic flow. It will help you to appreciate, it will help you to understand how much flow and what type of a flow pattern is towards is to the nodules. So this is complex lesion, this is serous cystadenocarcinoma, and these three images which I have shown you confirming that the style and the structure of the malignant serous cystadenoma would be like this. So I'm sure you will not miss these diagnoses whenever you come across during ultrasound imaging. Second most common surface epithelial tumors are mucinous cystadenoma and mucinous cystadenocarcinoma, as it has both potentials, the benign potential and malignant potential. So far, the benign potentials are concerned, it means mucinous cystadenoma accounts for 20 to 25%, and malignant accounts for, which is mucinous cystadenocarcinoma, 5 to 10%. So their malignant potentials are as compared to serous cystadenocarcinomas are very rare. So I will discuss first about the mucinous cystadenoma. Mucinous cystadenomas are the benign lesion, account for 20 to 25%, and it's usually seen in 3 to 6 decades of life. So you can see this type of a tumor in very young lady. And another characteristic of this benign lesion, mucinous cystadenoma, is it happens to be very huge, even up to 30 centimeter, and it will fill all the abdominal cavity. And in that case, it will fill the abdominal and pelvic region and will appear as a very huge mass. This would usually be benign, and this would be mucinous cystadenoma. On the ultrasonic feature, what you would see in that, you would see there will be multiple thin septation within it. There will be low level internal echoes. There will be gelatinous material within that, but there will be no papillary projections. Papillary projection can only be seen in a carcinoma patterns. So this accounts for 20 to 25% of mucinous cystadenoma. So far, the cancer is concerned, which is mucinous cystadenocarcinoma. It accounts 5 to 10%, and it usually seen between 5 to 7 years of life. In that decade, it could be seen, but the malignant potentials are very low. So far, the sonographic features for the malignant potential for the malignant cystadenocarcinomas are concerned. These include multiple loculation, but this would be thick loculation. There will be again there will be debris inside, gelatinous material, but the papillary projection is one of the major sonographic features for these carcinoma, for these malignant tumors. The one another point worth noting here, as I mentioned, that mucinous tumor, whether these are benign or malignant, happens to be very huge. So there is likely chance of rupture. When it ruptures, it causes abdominal peritoneal ascites, and that would be loculated ascites. There will be gelatinous material inside, and you would appreciate loculated ascites, and that type of condition would be considered as or called as pseudomyxoma peritonei. So this pseudomyxoma peritonei is a condition in which you will see all these ascites, septated ascites, but this would be secondary to mucinous cystadenoma or mucinous cystadenocarcinoma. If these both tumors ruptures, it will lead to ascites. But so far, the pseudomyxoma peritonei is concerned, it's not only caused by this mucinous cystic lesion. It may cause due to rupture appendix, or you can also see in other mucinous tumor, rupture of other mucinous tumors like colonic tumor. If it ruptures, it may also cause pseudomyxoma peritonei. It's not only just related to this cystic mucinous cystadenoma, but in case if it happens, because as I mentioned, this happens to be a very large tumor, very huge tumor, and there is likely chance of rupture. So when it ruptures, all of this fluid will go into the peritoneal cavity, in the abdominal cavity, in the form of ascites, and you will eventually see complex ascites, septated ascites. So how these both benign and malignant cysts will appear on the ultrasound images, how you will appreciate that these are serous, these are cyst adenocarcinoma, mucinous cyst adenocarcinoma, or these are mucinous cyst adenoma. So they are how you can differentiate it on the basis of the ultrasound. So let's start watching these images and you will be able to pick the point. On this abdominal scan, you can appreciate well-defined complex cystic lesion, and on this complex cystic lesion you can appreciate internal loculation or septations. These septations are neither thin nor thick. It's in a borderline and it's intermediate level, but this is mucinous lesion. How you can appreciate that and differentiate between these both serous and mucinous? Just concentrate on the internal lumen and you will see gelatinous material within the lumen. So that is the sign of mucinous cystadenoma. So this is an example of mucinous cystadenoma. However, this is benign lesion, as most of the mucinous cysts happens to be benign compared to the cystadenoma, serous cystadenoma. Now look for the surrounding wall. Surrounding wall is also thin. You can appreciate that some of the gelatinous materials, low level echos, has been deposited in the dependent part of the cyst. So this is an example of mucinous cystadenoma, which is benign, and most of the time mucinous cysts happens to be benign. On this transvaginal scan, one particularly important radiological pattern is visible. This pattern is known as spoke wheel sign. Spoke wheel sign, look in the center, multiple septation are arising from the center, and in the center you can find small nidus there, so it looked like a spoke wheel. In the lumen, thick gelatinous materials are visible, and these thick gelatinous material give rise to echogenic pattern. So this appears to be slightly echogenic. So this is the another sign. Now focus on the septation. These septations are thick, and these septations giving a particular pattern of spoke wheel, while if you concentrate on the surrounding and periphery of the cell, periphery of the cystic lesion, there is no thick wall. So thick septation, spoke wheel sign, along with gelatinous material, echogenic, low level echos, evenly distributed in the lumen. This is mucinous cyst adenocarcinoma. If you put Doppler signal on, so there will be vascularity in the septa. If there is not, because of some technical issues, but this is serous, this is mucinous cyst adenocarcinoma. So this is carcinomatous pattern. Difference between the serous and the mucinous is the presence of gelatinous material, presence of mucinous component. So if mucinous components are there, that would be mucinous cyst. If there is no mucinous cyst, only serous components are there, that would be called as a serous. So there is a very minor difference so far the radiology is concerned, because sometime on radiological basis you cannot easily pick whether this fluid is serous or this fluid is gelatinous, until these gelatinous materials are dense enough to pick on the ultrasonography. This is another transvaginal scan, and on this transvaginal scan again you can appreciate mucinous cystadenocarcinoma. What these arrows are indicating are septal nodularity. Again, this radiological pattern gives rise to a shape of spoke wheel. So spoke wheel sign is there in the center, indicated by the arrow. This is nodules. These are nodularity and nodularity of the septum. These septa are also thick along with the central nodularity, and if you look to the surrounding in the surrounding area, this cystic lesion looks like filled with gelatinous material because of low level internal echos. So low level internal echos are arranged or aggregated in such a pattern that it looks like there is something in the cystic in between the cyst. Radiological pattern of the mucinous cystadenocarcinoma includes nodularity, thick septa, septal nodularity or irregularity, and beside this in the lumen gelatinous material. So these gelatinous materials can be easily picked on the ultrasonography. So you can distinguish between the between the serous simple cystadenoma and mucinous cystadenocarcinoma. So this was the example of mucinous cystadenocarcinoma. There is another intermediate group of surface epithelial tumors that are also called as borderline tumors, or they may be called as low malignant potential tumors. These are common in both serous tumors and mucinous tumors, but usually these can be seen in early ages, and their prognosis are very good. 5 to 20 years survival rate are there, and they have a low potential. So far sonographic features are concerned, on the ultrasonography you can see a well-defined cystic lesion with a low-level internal echos, and this echos would be similar to endometrioma, so that's why it would look like an endometrioma. In some cystic lesion you can see intramural vascular nodule, or sometimes you can see in a cystic lesion there is a multiloculated internal nodule. So that would be considered as a low level or low grade malignant nodules. How it will appear on the ultrasound imaging? Let's start watching these images. This is transvaginal scan, and on this transvaginal scan you can appreciate a well-defined complex cystic lesion having low-level internal echos in the lumen. One important finding you can appreciate in the wall is papillary projection. So these are papillary projections. If you put Doppler on them, there is possibility of having vascularity, or they may not be vascularity, but this type of a structure is fall under the category of low grade or low potential malignant. It could be serous and it could be mucinous as well. So this ultrasonic pattern, this radiological pattern is suggestive of low grade malignant potential, either serous cystadenocarcinoma or mucinous cystadenocarcinoma. In the introduction, as I mentioned, that this type of a malignant cell does not involve the stroma. That's why the name low potential has been given to this cell, because its virulency, its malignant potential is lesser than the real malignant, truly malignant neoplasms. So this is low grade malignant potential. If you come across any cyst which shows low level internal echos with papillary projections, must consider low grade malignant potential tumor. Endometriod tumors. Endometriod tumors are almost always malignant, and it accounts for 20 to 25% of malignancy. Can be seen in 5th to 6th decade of life. However, their prognosis are very good if they can be picked in early stage, so it has a quite a good prognosis. But anyway, endometriod tumors are always malignant. Endometriod tumors is usually on the histological pattern similar to endometrial adenocarcinoma, and almost 30% of endometriod tumors are associated with endometriosis. This is one of the another point. Whenever there is endometriosis, you must look for the endometriod tumor as well. Ultrasonographically, it will be a cystic lesion, and it will contain papillary projections. Most of the time there will be papillary projection within the cystic lesion. At occasion it may be a solid tumor. Endometriod tumor happens to be a solid tumor with some hemorrhagic contents and some necrotic components. So how it will appear on the ultrasound imaging? Let's start watching these images to look for the endometriod tumors. As I mentioned that endometriod tumors, almost all endometriod tumors are malignant, and they are the second most common epithelial malignancy. And so far sonographic features are concerned, on this slide 4 images has been shown. These 4 images are example of endometrioid tumors. These are predominant cystic lesion, and they showing papillary projections from their wall. Towards the right side, a small tiny projection can be seen on the superior wall of the cyst. On the left side, there are multiple projections can be seen. In below, there is another image which showing small projections from the basal part, and towards the left side you can also see multiple projections. So this is an example of endometrioid tumor. So endometrioid tumor sonographically has two characteristic patterns. The one pattern mostly cystic, and the cyst may be these tumors may be predominantly cystic with having papillary projections in it. And the second form, this endometrioid tumors can also be present as a solid mass. So the second presentation would be solid mass. This example shows only predominant cystic lesions with papillary projections. On this image again, endometrioid tumor has been shown, but this is different radiological pattern. As I mentioned earlier that endometrioid tumors may be cystic, or sometime it may appear predominantly solid, having central hemorrhagic contents or necrotic contents. Focus on this image. On this image you can appreciate a well-defined solid mass. It's actually solid mass, but this is endometrioid tumor having central necrotic and hemorrhagic pattern. So endometrioid tumors can be either cystic, predominantly cystic, or it can be predominantly solid. But if it appears as a solid, you may be able to see central necrosis or central hemorrhagic contents. In case of cystic lesion, there must be papillary projection. So these are two radiological pattern of endometrioid tumors. Clear cell tumor considered to be Mullerian duct origin, and it is almost always malignant and accounts for 20 to 25% of malignancy of the ovaries. It usually seen in 5 to 7 decades of life, and even 70% of clear cell tumor associated with endometriosis. Whenever there is endometriosis or chances of endometriosis, always look for clear cell tumor, because it is almost always malignant. So far the sonographic features of clear cell carcinoma, clear cell tumor is concerned, their ultrasonic features are non-specific, but these are predominantly cystic lesions with low level internal echoes, but you cannot specifically say something because it keeps on changing its size, it keeps on changing its sonographic feature. So let's start watching these images for the clear cell tumor. This is the example of clear cell tumor. Clear cell tumor is considered to be Mullerian duct origin and a variant of endometrioid carcinoma. Clear cell is almost always malignant. On this image you can appreciate a well-defined complex cystic lesion. So far sonographic appearance of clear cell tumor is concerned, it usually present as a non-specific, complex, predominant cystic mass. So on this image you can appreciate a well-defined predominantly complex cystic mass with low level internal echoes. Papillary projection can also be seen, slightly thickened wall can also be seen, wall irregularity can also be seen. So on the basis of radiological pattern you cannot confirm whether this is truly clear cell tumor or some other, like it may include differentials, like it looks like dermoid cyst, it looks like hemorrhagic cyst, it look like serous cystadenoma as well, and many other patterns. So therefore their radiological pattern, sonographic pattern are not usually specific, these are non-specific, but it happens to be complex and predominantly cystic mass, which you can appreciate in this above image. Transitional cell tumor. Transitional cell tumor is also called as Brenner tumor. It's also arises from the surface epithelium, and usually it contains urothelial component. It is very uncommon tumor, accounts for 2 to 3%, and it's always benign. There is no malignancy in that. Patient happens to be asymptomatic, and this type of a tumor can be found incidentally. So far ultrasonic features are concerned, it happens to be hypoechoic, and surrounding with a calcified wall. Sometimes there is a wall calcification surrounded, and it is made up of fibrous tissue usually, so it's very easy to pick on the ultrasound imaging. And as I mentioned, it happens to be benign and very uncommon, rarely seen, about 2 to 3%. How it appears on the ultrasound imaging? Let's start watching these images. This is the example of transitional cell tumor. Transitional cell tumor is also called as Brenner tumor. On the ultrasound, Brenner tumor or transitional cell tumor will appear as hypoechoic solid mass with slightly irregular contour, and sometimes there will be calcification on its wall. On this image, a large cystic lesion can be seen. This large cystic lesion is actually large mucinous cystadenoma. If you focus on the wall, a hypoechoic solid nodule is arising from the wall. This hypoechoic nodule with having wall calcification is transitional cell tumor. Transitional cell tumors happens to be benign almost all the time. There is no malignancy, and you can appreciate that this large cyst is actually mucinous cystadenoma. So this transitional cell tumor is arising from the large mucinous cystadenoma wall. So this is example of Brenner tumor, and this sometime involves, or it may arise within another cystic lesion, most likely mucinous cystadenomas. Yes guys, this was all about the ovarian neoplasm, and I have discussed at length about the different categories of ovarian neoplasm, and especially in this video I have covered about the surface epithelial stromal tumors. Surface epithelial stromal tumor happens to be of 5 types. These include serous, mucinous, endometrioid, clear cell, and transitional cell. I have discussed each and every one at length, provided that I have just mentioned I have just explained on the images as well. So hope so that this video would be quite informative for you. When you are bumping into any of these type of cystic lesions on the ultrasonography, clearly define the descriptions, mention whatever you have seen on the images, and beside this give your differentials. If you think this could be this and that, mention on your report. And jumping to the next, it is better to follow up the cystic lesion. If there is any cystic lesion, just follow these cystic lesions within 2 to 3 months. If there is no change in the size, or if there is increase in the size or increase in the contents, or something suspicious you are observing during the scan, so now then you need to do is just jump to the next, and that is the next modality. MRI is the next modality, or histopathology. So always put that on your report. So hopefully this will help the patient and towards the diagnosis and proper management. So this was all about the surface epithelial neoplasm. Hope you would be able to get a lot of information from this video. If any confusion point you have in your mind, just drop me a message and I will get back to you with some new video. We'll see each other. Till then, take great care of yourself. Bye bye.